That's our brief outline for today. We shall start with a recap of yesterday's neuroscience. Yesterday, remember, we looked at diagnosis, we looked at the introduction to bipolar disorder. We shall look at the etiology, the heritability, the neurobiological aspects, and the cause before looking briefly at the prognosis of bipolar disorder. So as a way of recap, this is a summary of what we talked about yesterday. We looked at the fact that bipolar disorder includes several disorders of emotion, thought, and energy, and they are characterized by biphasic mood episodes. These can either be of mania, hypomania, and depression, mania alone, as long as we have the mood episodes. The patients, we looked at the criteria in detail for bipolar 1 and bipolar 2, and we also looked at the specifics of what a manic episode entails, what a depressive episode entails, and the different types of depression we discussed as well. We looked at the fact that in bipolar disorder, sometimes we have a lot of misdiagnosis. Why? Because the symptoms of bipolar disorder overlap with many other disorders, including the unipolar depression. Sometimes it may be initially difficult to tease out which depression is attributable to bipolar disease and which one is strictly unipolar. The schizophrenia and the other psychoses, because with bipolar disorder, we saw that we also present with psychotic symptoms in addition to the mood symptoms. Then we can also misdiagnose this with substance-induced disorders. So there is need for very careful assessment of previous mania or hypermania in patients with depression before concluding on the diagnosis of bipolar. We looked at the common risk factors. We highlighted childhood maltreatment, psychological stressors, substance use, occupational and socioeconomic status, and highlighted the importance of looking at all this in the history when we are in touch with our patients. We also looked at the increasing use of ambulatory monitoring using gadgets, which can be wearable gadgets, smart like a smartwatch. These are being used to monitor patients' symptoms, to monitor their energy levels, to monitor their mood, and even digital phenotyping, where the digital use of this person is monitored and analyzed. For example, looking at their social media windows, how often are they using them, what are they doing, so that the behavioral parameters are assessed in real time, and this greatly impacts on the treatment. We also looked at the importance of brain biomarkers, which we shall highlight even more today, for informing diagnosis and setting targets for treatment. So we proceed to today's topic, which includes etiology of bipolar disorder. Excuse me. So we have noted previously that bipolar disorder, the cause is not fully biologically understood. However, time and again, it has been seen as a result, it has been described as a result of an interplay of various factors. As you can see in the illustration, we have environmental factors like early life trauma, the childhood maltreatment we talked about. We have other substance use and stressful life events under these environmental factors. These interact with the genetics of an individual, and there is an increasing number of genome-wide association studies that are suggesting that there are many genes that function to cause pathology, many genes that are impaired, many genes that are affected and end up leading to bipolar disorder. This has also looked at the calcium channels under the genetics, and in addition to environment and genetics, there are biochemical processes that have been outlined as contributing to bipolar disorder when they interact with the environmental and genetic. And these include the processes that lead to cell damage, chronic cell damage, mitochondrial dysfunction, inflammation, and impairment in cell function. So the most common is inflammation. We shall start with that. Inflammation, I'm sure we are not just looking at it today as part of the etiology of a psychiatric illness. We remember very well in depression, it was highlighted greatly. But it has been observed to play a role in several mood disorders, like we've already seen depression, but specifically the brains of people with bipolar disorder carry many hallmarks of inflammation. We shall be seeing them. There are researchers that have analyzed tissue from the postmortem frontal cortex of people who previously had bipolar disorder, and they have studied levels of inflammatory markers. And they have compared this tissue, the inflammatory markers in this tissue, with control brains. And whereas the NMDA receptors, the levels of the receptors and their subunits were reduced, there were many increased inflammatory markers, including interleukin-1 beta, MYD88, astrogio and microglial markers, and INOS. We remember that's inducible nitric oxide synthase. So all this suggests that the bipolar disease comes about due to excessive excitement like excitotoxicity and neuroinflammation in the brain. So PET imaging has shown that, has actually shown us which areas, which structures in the patients with bipolar disorder had these signs of inflammation compared to the controls. One of the highlighted areas was in the right hippocampus. And there's a study that has reported lower numbers of oligodendrocytes in the brains of people with bipolar disorder. Now, even before this, researchers had previously connected immune system and mood disorders by observing sickness behavior. It was observed that people who had an acute inflammatory illness usually also presented with behavior changes. They were moody. They had changes in mood, and they were really mimicking psychiatric conditions, but it was two directional because even those with mood disorders were being seen to have a greater risk of autoimmune conditions than the general population. So that's what caused these various researches to investigate the possible roles of the immune system and inflammation in the pathology of mood disorders, including bipolar disorder. And if you can think back, if you have worked on the medical ward or the HIV unit, you may have realized that this chronic inflammation that has been brought on by HIV leaves the patient with some sort of behavioral changes. The relatives will even tell you that the mood has been different since the onset of illness. So we have looked at inflammation. What happens with immune activation? So bipolar has also been associated with immune system dysfunction. And this comes from the observation that people with bipolar seem to have higher rates of immune system comorbidities. So, but since, sorry about that, correlation does not necessarily mean causation, it's very possible that bipolar disorder and these other inflammatory conditions share common pathologies, or the immune function comes from the bipolar disorder. We've already seen that there's a lot of inflammation going on. And it kind of also becomes complex. It becomes like a vicious cycle. that the bipolar is leading to higher immune dysfunction, and yet even immune dysfunction is increasing the likelihood of bipolar disorder. But there has been some evidence. Why? Because along with the inflammatory cytokines, some lines of evidence, like you can see on the slide on the left, have suggested that white blood cells may be regulated in patients with bipolar disorder. For example, the monocyte and lymphocyte activation have been observed. T-cell imbalances have been observed, and a systemic toxicity index has been developed. This index has a set of targets that are considered, and they are related to oxidative stress, neurotrophins, and inflammation in patients with recurrent mood episodes. So these are seen as key mediators in the cognitive impairment and also generally the general health impairment, because you'll find this person more likely to be sick physically as well. So as we treat our patients, as we assess and manage and monitor, it is important to make sure that we are preventing these bodily changes, these transformations that can cause progression of bipolar disorder. How? We are seeing the interleukins involved, the immune dysfunction, the inflammatory conditions. These are all associated with high stress levels. They are all associated with obesity. You know, we do not want extreme activation of the HPA axis. So we have to bring all the interventions to reduce that activation, reduce the cortisol. We know that excess adipose tissue is active metabolically and it secretes pro-inflammatory molecules, the adipocytes. So it leaves this person in a chronic inflammatory state. So as we look at this biology, let's think back to our patients. How are we advising them as far as exercise and stress management is concerned, and also diet? So I hope we are still together. We have looked at inflammation, we have looked at immune system dysfunction, and now we get to look at the interesting microbiome. So the microbiome is, these are basically the gut microorganisms, the gut flora, and they have been increasingly studied because they have a wide range of effects on the human body. And differences in this gut flora can lead to differences in lactic acid metabolism. So we know that there's the gut-brain axis. And so when the lactic acid metabolism is impaired, we are also going to affect the production of butyrate and GABA. And we know that these are explanatory for the pathology of mood disorders, including bipolar disorder. So of course, the microbiomes that are observed from people with mood disorder is different from those with control, but it's a relatively new field and it is very difficult technically, because remember, you're getting these microbiomes from, you're getting this flora from stool. It's going to be very difficult. It's not easy. It's not easily reproducible. It's not easily comparable from one individual to the next. However, to manage chronic inflammatory states, autoinflammatory diseases, inflammatory bowel syndromes, there has been a lot of progress. We have seen fecal transplants being done for those who have chronically low amounts of gut flora, and a healthy donor provides these microbiomes, and they are placed in the gut of the person that is deficient. That has been done for the autoimmune disorders and the chronic inflammatory states. However, for bipolar, we are still a long way to go, but it has been implicated that these gut flora have a role to play in the development of disease due to association with the gut-brain axis. So I put in this slide on neuroimaging because, like our moderator said, we need people to have evidence that this is actually a biological illness. And yes, there are tests that have been done. There are radiological studies. Here we look at MRI, magnetic resonance imaging, and there was a large meta-analysis of functional MRIs, which concluded that across mood disorders, there was reduced inhibitory control and salience processing. So we can see these pathways on the right in our illustration, that there's altered white matter connectivity in the corpus callosum and in the cingulum. So this was identified for future use as a biomarker for bipolar disease. There have also been structural abnormalities noted. Not only functional studies have been done, and the results have shown that much as they are heterogeneous, the people with bipolar disorder have clearly impaired structure and function compared to the ones without disease. And these structural abnormalities have been mainly noted in the white matter. So we look at the genetics now. Again, well, I've mentioned genome-wide association studies before, and in 2019, these were done on large groups of people, and they implicated several pathways in the body because processes were noticed that are similar to what happens in the bipolar disease process. For example, abnormal motor coordination was noted among those that had the bipolar disease, abnormal locomotor activation, abnormal voluntary movement, and we shall see the slide with the particular foci, the particular genes that were involved. And when this was analyzed further, it was realized that the results slightly overlap. So the bipolar 1 and bipolar 2, for example, they are very close genotypically, but as phenotypes, they are distinct. So it wasn't very easy to differentiate the two subtypes simply because of the overlapping. However, bipolar disorder 1 was noted to be more related to schizophrenia, while bipolar 2 was more related to depression. Heritability, yesterday I think we emphasized that it is highly heritable. Heritable, I think I can use another synonym. It can mean transmissible from a parent to an offspring. Other words are ancestral, hereditary, inheritable. So generally, it can be passed on in families. And it has been investigated in family studies using twins and adapted pairs of children. It has also been used in cohorts and population studies. And those are the results. The heritability is 0.73 for bipolar 1 and 0.77 for bipolar 2. You can see that when you compare on the right, this graph comparing the different disorders, it is clearly higher heritability of bipolar disorder than the other conditions, schizophrenia, alcohol use, major depressive disorder. So when we look at the loci, these are the different genes I told you. There were over 60 that were identified, these genome-wide association studies. Those were the potential genomic loci of interest, and they were collected from 20,000 people, 20,352 people who had bipolar, and 31,300 who were controls. And 30 loci were associated with bipolar, including genes encoding ion channels, neurotransmitter receptors, and synaptic components. So they were already implicated and proved because of their response to antipsychotics, calcium channel blockers, and antiepileptics, which has a big impact on treatment. So this, I'll just add that studies into bipolar, autism, and schizophrenia have also revealed an overlapping risk among these three. And there's involvement of proteins associated with synaptic development and plasticity. So you can now understand why environment plays a very big role, because environment is what brings about the neuroplasticity, how the brain is able to learn from what happens and adapt to the different changes. So this contributes a lot in the development of bipolar. So there were a lot of determinants like first degree relatives who had either bipolar or schizophrenia. It was a high risk for the person to be having the disease. So different models have been explored. The high PSCs have been used to study the pathology of bipolar. These are human-induced pluripotent stem cells. So cells from a person with bipolar are used to create a culture of neurons. So when these cultures were manipulated and studied, that what was produced reflected what you would get from the hippocampal-dentate gyrus neurons, meaning it now showed us another structural component of the disease. So, excuse me, these studies suggest that compared with the controls, neurons derived from people with bipolar had changes in ion channel expression. And we can see the interactions between the genetics and the environment leading to bipolar. When you have that particular genotype, combined with the cellular abnormalities, there will be circuit issues, and then this will make up what type of disease we have. All that in combination with the environmental factors. Human functional analysis. This is quite advanced research, but cells are removed from brains of people with bipolar disorder, and when compared to those without bipolar, they were found to be hyperexcitable, and they were only hyperexcitable if they were removed from people that had been lithium responsive. Animal models have also been used to mimic the behaviors of people with bipolar depression, especially the manic episode, but also the depression, the risk-taking behaviors, aggression, and these have also led to the conclusion that there's a neurobiological component in causation of bipolar disorders. So when we go into the cause, we can see from the slide that apart from being a cyclic disorder, bipolar can progress over time. So we are not having an exact circle that we are going to have an episode, go back to the point where we were. No, actually the next episode may be worse than the previous because we are progressing to chronicity. The first stage is vulnerability, which is the prodromal phase. That's how we refer to it, where some features can be observed and they can indicate that somebody is likely to get a mood episode. So those are the symptoms. We looked at them yesterday, and that is the horizontal axis shows us how these symptoms interact and progress to chronic states. So this is just to highlight to us how important it is to identify these patients early and manage them well, because someone doesn't have to reach the very chronic stage where they are greatly impaired. And this brings us to the importance of staging. Staging has been accepted as a component in many specialties of medicine, especially in tumor staging, but many times in psychiatry it's overlooked. And it simply refers to the characterization of a disease according to the seriousness, extent, and the features. So if we were staging, we would put a feature, an individual with a psychiatric disorder on a spectrum, which would encompass clinical progression, but the stage you have here, it's looking at severity. But if the ideal would be to have one that can show us the progression from prodromal to pre-disease to acute and then to chronic, and then so we would have stage 0, 1, 2, and different people have proposed stages. Back proposed a stage about severity of symptoms. Duffy developed a model that emphasized early development, that the prodrome, before a patient gets into acute illness or chronic illness, can you please stage and see what we can modify in their environment? So this is the Kapczynski model of 2009, which was based on studies of patients with established um, bipolar disease. And it's focused a lot on what happened in between episodes. So before the episode actually came, what did they look at to stage to say this is latent bipolar disease? Family history, history of mood symptoms or anxiety symptoms, which were below the threshold for bipolar. Then stage 1 through to stage 4. As we can see, there are well-defined periods of euthymia without overt psychiatric symptoms, progressing into symptoms, marked impairment, and eventually the inability to live autonomously because of the cognitive impairment and the functional disability that is caused by disease when left to progress. So now we look at vulnerability. We have seen the different symptoms under bipolar disorder. We have seen the possibility of staging. We have seen the causation. How can you tell that this person is going to be at a high risk of this is a high risk patient for bipolar, and you raise your index of suspicion? So the precursors, you can see them listed there. Most very important is to look at the prodromal stage. A systemic literature review published in 2015 found 26 prospective studies of the precursors of bipolar, and they identified different precursors, which you can see. Mood lability. You interact with the relatives and they say this person has actually always had an unstable mood, or they had a depression, and like we've seen many times before the first manic episode, there has been a subthreshold or a major depression. They've also had cyclothymic disorder, psychotic symptoms occurring in major depression. So let us be very careful, especially when we diagnose psychotic depression or depression with psychotic features. We have to closely monitor those patients, because that is part of the prediction that this person may develop bipolar disorder. Another very important factor is age of onset. Early onset of depression predicts development of bipolar disorder. And then frequency and loading of the mood symptoms. So this is still about the prodromes, what is happening before the person actually gets active disease. Different scales have been used to study that period, the prodromal period, but other precursors are affective temperaments. Kraepelin introduced the concept that trait-like manifestations, may be associated with mood disorders. For example, the temperaments, are not really significant disease, but they are symptoms that can describe someone who may eventually get a mood disorder. And the four major ones are the dysthymic, cyclothymic, irritable, and hyperthymic temperaments. And there was an analysis which found scores between mood disorders and healthy controls to be as put in the slide. On the left, you can see that cyclothymic and irritable temperaments were higher in patients with bipolar than in those with major depressive disorder, and they were higher in patients with major depressive disorder compared with controls. So that TEMPS is a scale, the temperament evaluation, Memphis and San Diego questionnaire. It has a longer name, but that's what I can remember. But it evaluates temperament, considering the four major ones that I have mentioned. So as we assess the cause and the prognosis, it's important to understand the disorder cause specifier, which highlights the predominant polarity, which pole has been affected more. Does the patient have mainly depressive symptoms, or they are mainly manic? So it has, excuse me, it has implications on the treatment, and there are varying effects of the drugs across the polarity index, as we shall see tomorrow. So if you have more depressive poles, it means that the person, if the person is more on the depressive pole, it means that it's more likely that they are bipolar 2. Diagnosis is likely to be delayed. Index episode is most likely depressive, and they have higher rates of suicide. Whereas if they are predominantly on the manic pole, bipolar 1 is more prevalent. There's a lower age of onset, and a higher rate of substance abuse. So this is specifically looking at the age and polarity at onset. There's a large study which investigated the clinical and genetic factors associated with age and polarity of onset among over 19,000 people. And earlier age was associated with the probability of psychotic symptoms, associated with suicidality, lower educational attainment. Why? Because this person, their function is going to be impaired and they won't be able to attend school as they should. Inability to live with a partner because of this lability of mood and the symptoms generally not being understood. It was highly associated with the inability to. So when you're doing the relationship history, it's important to examine some of these details. Why? How come they've had all these partners? What was the issue? So we continue with specifiers. We've looked at polarity, we've looked at onset, we've looked at severity. Now the types of cycles. We can classify this depending on the order of mood episodes, whether it was depression, then mania, then depression. It's associated with different responses to treatment and with different clinical symptoms across the course of disease. So one study which compared the type of cycling in a sample of 855 people found two predominant types, as you had guessed: depression before mania, 15%, and depression after mania, 14.6%. Now, those are the early stages. We're looking at the prodromal stages. What happens early in the life of this person? It's very advanced before we go into a chronic state. We have seen that there is inflammation, there are anatomical changes going on, functional and cognitive impairment, and we shall also see now that we are in late stages, that these people, the cognitive impairment doesn't just stop at that, they progress to dementia. So late stage bipolar disorder is characterized by less symptomatic recovery between episodes. What does this mean? This means we are going to have higher impairment of function. So the late stage disorder is different from a disorder of late onset or of long duration. Late stage disorder, we are saying what happens at the end stage after you have been through the prodromal, acute, chronic, what happens, not when somebody gets the disease later on in life. So those who get late stage bipolar, they have a poorer prognosis. If we manage to control it earlier, the prognosis is much better, because if we get it early, manage to get the correct regimen, that there will be a better, less impairment of function and a better quality of life. So a person who experiences persistent mood episodes and only partially recovers, they never function, their function never goes back to baseline or to normal, and they are persistently impaired for 2 or more years. They are referred to as chronic bipolar disease. I'm sure we have seen some of these. So now that we have appreciated the different stages, inflammation, anatomical change, functional and cognitive impairment, what can assist us to correctly assess this stage and estimate them? Since we saw that the white blood cells are affected, we shall see increased levels of white blood cells, the monocytes, the T helper cells, as we saw, increased levels of inflammatory markers. We saw the interleukin-8 and others were decreased telomere length. All these can be used to stage bipolar disorder, to know at what stage are we. And structural studies of the brain, we were looking at the white matter effects, but now we are seeing even decreased gray matter volume causing functional and cognitive, contributing to the functional and cognitive impairment. All these have been investigated as potential biomarkers of progression. When we look at the brain, even an increase in ventricular size, this is usually coupled with that reduced gray matter volume. They are linked to progression of disease. So it's important to understand the disease process, to know where we are, to know whether the treatment is working, and to help us manage the patient better. Let's stage, I know I've already mentioned dementia as part of the cognitive impairment. And it has been linked, bipolar disease has been linked to an increased risk of developing dementia. This meta-analysis that was done on all those people, over 6,000, 2,614 developed dementia. When we looked at the control population, 487,000 controls, only 115 of them developed dementia. The odds ratio was 2.96 with 95% confidence interval. This meant that somebody with bipolar was almost 3 times, 2.96 times, almost 3 times, was 3 times likely, more likely to get dementia than the control individual, the person without bipolar. And this risk is put at 0.5 when you give lithium. I won't go into lithium now, but tomorrow we shall see that it has been considered as a wonder drug. One suggestion would be to improve the course to manage this late stage bipolar when function may not have chances of being restored, is to do palliative psychiatry, which focuses on mental health and improving quality of life. and may not do much with the symptoms, apart from assessing them, periodically supporting the planning, assessing the caregivers, seeing whether they need some respite care, and referral to other specialized services. So there's a suggestion that apart from having palliative care in other specialties, we introduce it in psychiatry as well. So in prognosis, the long-term course of BD of bipolar disorder is chronic, and patients experience fluctuating symptoms over time. But you can see that the longer you spend without symptoms, the better the prognosis. Long-term recovery, we can see in bipolar 1, there's a higher likelihood of depressive episodes, and half of patients don't fully adhere to their medication, so they may not have a sustained recovery. You can see that the curve is going down. It's usually comorbid with other conditions, so it's difficult to assess. Relapse rates, this also forms part of the prognosis and the cause. The relapse actually increases the number of with the number of previous episodes. If someone has had many opposite episodes, they are likely to have even others, and this greatly affects their functioning and quality of life. They are burdensome for the person with disease and even for their family and society and workplace and so on. And functional recovery usually lags behind clinical recovery. Without optimal clinical recovery, it's difficult for someone to attain their function and be satisfied with their social roles. They are meeting their roles as a parent, as an employee, and they're having less anxiety. So it's very important. It goes without saying that adherence to treatment is a big factor when it comes to return to function. This is a long list of tools that can be used to assess progression. Because as the years go by, there's increasing interest in functional recovery. This is becoming a very important goal in treatment of bipolar disorder, not just the removal of symptoms, but is somebody able to get back to their normal function? So
Dr.
they are the
Cameron,
ones on the list. Yes, please.
can you summarize, please?
Okay, so I think this is the last also. Premature mortality, we looked at that yesterday, that bipolar disorder causes earlier death, and aging impacts aging. And in summary, that's the summary. The exact cause is not fully identified, but bipolar disorder is seen to arise as an interplay of genetic, environmental, and biochemical factors. Several models have studied bipolar, including animal models, stem cells, post-mortem tissue analysis, and functional analysis of the brain. Um, Hopefully, in the next decade, there will be more individualized care. The long-term course of bipolar is chronic, so patients need to be monitored as they experience that fluctuating symptoms, and they are improving their quality of life. In addition to just alleviating the symptoms, is one of the important goals, and they aid the patient's recovery. Thank you so much for listening. Hope you'll attend tomorrow to look at management. Thank you, Dr. Mugume.
Asante sana, Dr. Kemerembe. We want to applaud you for organizing this presentation and being able to dissect it to its limbs, and we can appreciate what bipolar is, understanding the neurobiology. I will jump exactly into the questions, so don't drop off. The first question is from Agnes Bukira. Her question was not very clear, but she asked, are we talking about, I don't know if she was asking, what are we talking about when we say early or late onset? I don't know if you want to take a question at a time and then we can go to the next.
Thank you. I was just trying to look for the question so that I can have a look at it. Dr. Mugume,
there's a time that you were talking about.
Oh, she's asking that, are we talking about ages?
In prognosis, when you were talking about early and late onset, I wanted
Yes.
to ask, is it, I think, Agnes, could you please unmute and ask your question properly?
As she unmutes, I think I mentioned about late onset, but also earlier age of onset. Now, when I was talking about risk factors, what risks are you looking at that will increase your likelihood of having a fully blown bipolar disorder? The early age of onset of symptoms is what I referred to. But then when I said late stage bipolar disorder, I referred to what happens at the end when there has been that neuroinflammation, there have been the cognitive changes. That is when you're getting this dementia, which otherwise shouldn't have happened. And it's not about the age of the person, but it's about the stage of disease. Okay, thank you. I don't know if there's.
Yeah, thank you very much. What I was asking is that when you say early onset or late onset,
Yes.
my question was about, is there an age that you're using, an age bracket you're referring into when you're saying late onset or early onset? Thank you.
Okay, so we know that there are two peaks when we are referring to age. Excuse me. Okay, so when we are referring to age, we remember that two peaks, 24 and 25 to 45 years. So that's the late and early. But I think your question is in relation to the end stage symptoms that I described, the dementia. But if we are talking about the early onset, it's of bipolar disorder. It is that late teen, early 20s. That's the early onset. That's when we get symptoms early, and it's a high risk factor for bipolar disease and for severe bipolar disease. Is there any other? I hope you're okay, Agnes.
And the other question is from Sarah Nansozi. And she asks, what are effective temperaments and how do they relate to bipolar disorder?
Effective temperaments.
You mentioned them a lot.
I talked about the cyclothymia, the dysthymia, the irritability. You know, those temperaments are somebody's general state of mood. And these do not indicate disease. It is just, please don't confuse them with the temperament types when we talk about personality, the melancholic, choleric, sanguine, and phlegmatic. That is more into personality, but this is describing a temporary state of mood. And those were the cyclothymic, dysthymic, irritable, and the people who have the cyclothymic and dysthymic are more likely to have a manic pole of bipolar disease. Then the ones who have the irritability are more likely to have the, did I say depressive pole? Cyclothymia and dysthymia are more linked with the depressive pole, whereas depressive bipolar disease, whereas the irritability is more associated with mania.
Okay. Then Musa Muhammad, as always, being very attentive, he does sincerely appreciate and thank the organizing team and the presenter of the day, Dr. Kemirembe, for the insightful and well-delivered session on bipolar disorder, and that it helped him to understand deeply the complexity of mental illness and highlighting key areas that continue to challenge clinical practice and research. His question is, what are the precise neurobiological mechanisms and genetic factors that trigger the shift between depressive and manic episodes in bipolar disorder? And how can understanding these mechanisms guide more effective personalized treatments?
Okay, thank you very much, Mohammed. You've taken us to shifting of the mood from mania to bipolar, which is not um, a very well described, but the same applies, that it will depend on the genetic factors, the environmental, and the biological mechanisms that are happening, um, all acting within the neurocellular system to bring a shift of those moods. But otherwise, I did not find a description of the biology of what happens during that shift. I don't know, Muhammad, if you had something that you can share with us.
I think, and yesterday he did ask the same question of, he has observed that in treatment of bipolar disorder, they do give SSRIs, TCS, among others. And he finds that every time the patients have been given those, they shift. I think that's why he wants to understand with the neurobiology that you've described, how that relates then into the treatment, or how it guides the treatment to say that this one will get an SSRI, this one will get a TCA, or this one should get a mood stabilizer from the neurobiology that you just gave us.
Okay. All right. Thank you very much. I think we shall handle that adequately in the presentation on treatment, management principles, and how to choose the treatment for a specific individual. And that will be our session for tomorrow.
The other, the others are just really congratulatory messages on a great learning experience, well done by Tahil. Then we had from Mary Lillian saying, well done, Dr. Kemilembe. Navak was saying, thanks, doctor. Dorena saying, thanks. Thank you, Lord's Neurotorium team. We are happy to receive those congratulatory messages. In our midst, we want also to acknowledge Dr. Birabwa. I don't know if she's still on the call, but at some point she was around. Again, to give her 1 or 2 minutes to hit the nail on the head concerning what the presentation is today. If she is on the call, please, Dr. Birabwa, feel free to unmute and give us a word or two in regards to today's session.
It's not on.
Okay. We want to, we are left with 3 minutes. We want to again thank you for taking in the time to listen in. Please be reminded that we have all these resources on the neurotorium.org Dr. Moses, could you share the website again in the chat? Take time to go and recap most of the things that we have so far talked about in this series, and also to understand deeper some of the things that maybe during the presentation seemed very alien. But again, we'll be here tomorrow, same time, 7 to 8. And we'll be tackling, I think, the most vicious of the topics when it comes to mental illness, which is management. And Dr. Kemembe will help us to, again, dissect when we talk about management, what exactly are we talking about? With that, I would like to thank you once again and to wish you a good evening, and to hoping to see you tomorrow exactly at 7 p.m. and then we'll run for one hour. Thank you once again. Have a good evening.